you please tell us the specific efficacy and safety data from the phase 2b/3 trial for Clesrovimab, and maybe some of the findings that were observed regarding its use in both healthy and high-risk infants?
So we have two studies. The first, I think, is the one you're referring to, which is Protocol 4, our phase 2b/3 study. It's double-blinded, placebo-controlled, multi-center, and it was conducted in over 22 countries. And what we're excited to bring is that Clesrovimab demonstrated 84% efficacy against RSV hospitalization and over 90% efficacy against RSV lower respiratory infection hospitalization. And that was coupled with a safety profile that demonstrated that its safety was generally comparable to that of placebo in this study. That's paired with study in high-risk infants, Protocol 7. Protocol 7 is our Palivizumab controlled study in high-risk infants, for example, babies with congenital lung disease of prematurity, congenital heart disease, or prematurity itself. And it had safety as its primary endpoints. And in that study, we demonstrated that Clesrovimab's safety was generally comparable to that of the comparator, Palivizumab, used in that study. Moreover, we collected the PK data that will enable us to bridge to the efficacy that we've demonstrated in Protocol 4, the healthy baby study. So taken together, this set of data supports the use of Clesrovimab in both healthy infants and high-risk infants for the prevention of RSV as infants are entering their first season. In total, across both the studies, we've had 27 countries, many investigators, and over 4,500 families participating. And it's really their collective efforts that has brought this data to life. It's a real honor to be able to represent all of those folks.
Can you tell us how might the approval of Clesrovimab change clinical practice guidelines for managing RSV in infants, and what impact could it have on hospitalizations and healthcare costs?
RSV is the most common cause of hospitalization for infants in our healthcare system. And up until now, therapy, when you're treating RSV, it's really about supportive care. It's about intravenous fluids when a baby is so short of breath that they're unable to feed adequately. And it's about supplemental oxygen when a baby is hypoxemic and is having increased work of breathing. And all of that fills our emergency rooms, our doctor's offices, and our pediatric wards every winter. So efficacious and safe prevention like Clesrovimab offers really affords the opportunity to empty the emergency room, the PD emergency room, empty the PD wards in the winter, and really alleviate the health system and infants who really suffer under the consequences of RSV every winter. So effective RSV prevention is really a game changer for pediatricians, family doctors, pediatric nurse practitioners, all the HCP community that takes care of our kids.
To further elaborate on helping out healthcare workers, how can this simplified dosing regimen improve adherence among the healthcare workers? And do you anticipate any challenges integrating it into a routine pediatric care?
As you just alluded to, Clesrovimab is the same dose for all infants. So it's the same dose regardless of weight and regardless of whether a baby is born in the RSV season or outside of the RSV season. I think for busy pediatric and family practice offices, really simplifying the means by which you administer prevention offers a great deal of convenience and simplification of the workflow through a morning or an afternoon session. So I think that's an important enhancement, if you will, of the seasonal care that doctors and nurses are delivering when they're doing RSV prevention for their babies. The second question you asked was any challenges in implementation. So to address that part of your question, I think that child healthcare providers, pediatricians, and family medicine doctors have really learned a lot through influenza prevention. and through the delivery every winter season of influenza prevention to their babies. And I think they can leverage those learnings in delivering and implementing effective RSV preventative care as well. I'm sure there'll be wrinkles along the way, but I think it'll be like incremental change on top of influenza prevention. I think there's another aspect of this that also should be called out. You know, a lot of doctors have been accustomed to delivering RSV prevention to high-risk babies for whom there's been RSV prevention in the form of Palivizumab available for many, many years. And so this will be an extension and a change in practice where RSV prevention isn't focused so much just on the high-risk babies as on both the healthy and the high-risk babies. That is to say, all babies, because while high-risk babies are, of course, highest risk, all infants are at risk of RSV disease, especially that first season when they're the smallest. I think Clesrovimab offers the opportunity to deliver RSV prevention to both healthy and high-risk infants, and it's proven both safe and efficacious in preventing mild, moderate, and severe RSV disease. And with that said, Sophia, thank you so much for the chance to talk.
Yeah, thank you so much.